presentation. Go ahead.
I am chef de clinique in Saint-Luc Hospital, Brussels, in Belgium, where the chief of department is Professor Haftopoulos. I am specialized in vascular surgery, tumor surgery, and I am responsible for the monitoring of INPH in our hospital.
Okay.
I will try to.
Okay, well, let's give it a shot.
Just a minute.
Yeah, this is new to a lot of people. I think you may have logged off accidentally. Are you there, Geraldo?
Yeah.
Okay. You click on the share button at the bottom.
Yeah, here.
There you go. Okay, there you go. Okay, there you go. You're on the way.
Okay.
Yep, you're on your way. Just resize it. There you go.
It's
Perfect.
okay.
Okay, it's all onward.
Okay. Wow. I will speak about ICP monitoring because in our department is the golden standard for the workup of this kind of patient. Well, INPH is communicator hydrocephalus, and idiopathic is of unknown pathology. The guidelines for the diagnostic is gait apraxia, like our colleagues said, but we need at least one or two more symptoms, like dementia or urinary sphincter dysfunction. The events ratio is above 0.3, but in many works is kind of evaluation remains a rough measurement because we can't say if the patient will respond or not if you make a shunt derivation. Well, the difficulty remains in the selection of the patient for this treatment. And we have many kinds of workup, and the majority is invasive tests, like the TAP test, the Fisher test, the infusion test, the external lumbar drainage, the ICP monitoring is our principal arm for this workup for us, and even index. ICP monitoring, we can make a measurement in intraparenchymal or ventricular measurement. In our department, you use only ventricular measurement. And we analyze the waveforms, the ICP. I will show later about this. The lumbar infusion test we don't use in our department, but many authors have a good experience with this kind of test, and they can measure the open pressure and resistance of CSF flow. It is a good test, but we don't use it in our department. The TAP test is more simple and is come measure, but we can have a good response for the patient and decide to put the shunt, but this test can see if the patient will have a good response after the surgery. The external lumbar drainage, some authors use this kind of workup. The rate of drainage is 5 to 10 millimeters per hour. And some authors use during 3 days, and some authors are 7 days for this kind of evaluation. And after and before the test, you have the evaluation of gating tests, minimal mental state, Kiefer score, etc. But like I said, we will talk only about the ICP monitoring in our department. But we can see here in department neurology, they have more or less 10 patients per year for the workup of this kind of pathology. And only 2 patients are sent for shunting every year in this department. For us is very few. In our department, you have more or less 15 patients a year for the monitoring, and more or less 13 patients after the test can go to the shunting procedure. We see here we have a under diagnostic of this pathology in our department. For the ICP monitoring, we have first to put the drain. We can put the drain in frontal horn, or for the boot hole in parietal superior part of the cranium of the skull. But it's very important to avoid to put the tip of the catheter in the temporal horn. The better position is the bud of the ventricle to a more precise measure of the pressure. Bon, for the intervention is very easy, a little borehole and the position of the catheter for the monitoring. Lundberg in 1960 described 3 kinds of waves. The plateau waves, they describe with amplitude in between 40 and 100 millimeters of mercury, and a duration of 5 to 20 minutes. The B waves, a few circles in between 0.5 and 3 seconds by minute, in amplitude more or less the 20 millimeters of mercury. And the C waves for 8 minutes, the amplitude and more than 20 millimeters of duration. But they describe that the B waves is the most important wave to consider the patient like INPH to go to the surgery. Our chief, Professor Raftopoulos, make a research about these waves, and he describes analyze the Lundberg monitoring, and we describe 4 kinds of waves: the small symmetrical waves, the great symmetrical waves, the intermediate waves is the asymmetrical B waves of Lundberg, and the plateau waves. The ICP monitoring, you have the small symmetrical waves, 2 cycles per minute, a slight amplitude with a symmetrical shape. I will show in another slide the kind of wave you can see. You have the great symmetrical waves as ICP monitoring fluctuation with the amplitude more than 10 millimeters of mercury, and the peak with 15 millimeters of mercury. You have the intermediate waves, that is the B waves, is a wave of important amplitude avec, with variation, increase duration in a symmetrical shape. And this kind of wave forecast the plateau waves. The plateau waves is a wave with a decreasing phase shorter than the ascendant phase, and a long plateau phase, and the amplitude is more than 10 millimeters of mercury. You can even see 100 millimeters of mercury. Here you have in the row 1 and 2 no waves. You have the record that appear flat or near flat. The brain only sustains the stress generated by the pressure pulse. The row 3, you can see the small symmetrical waves, ICP monitoring fluctuation of slight amplitude with a symmetrical shape and a frequency of 2 cycles per minute. The row 4, you have a great symmetrical waves, and ICP monitoring fluctuations with amplitude superior than 10 meters of mercury, and peak between 15 millimeters of mercury. The row 5, you have show the B waves, characterized by an important amplitude and increased duration, and also in asymmetrical shape. And this wave forecasting the plateau waves. You can see in row 6, the plateau waves display one or more waves with a decreasing phase shorter than the ascendant phase, and result in an asymmetrical configuration with amplitude greater than 10 millimeters and a long plateau phase. And we can see sometimes 100 millimeters of mercury. In 2005, McGill confirmed the same description than Professor Raftopoulos said in 1992. Here you can see a patient that came to our department for the test, and you can see the test with the kinesiotherapy. She has a frontal gait disorder with ataxia, with a very difficult march or a walk for this patient. We can see here she has a great difficulty to stand up. She has a tendency to reverse, fall backwards, even with the help of the kinesiotherapy. And for the walker, it's very, very difficult. Here, in seated position, the patient has always the tendency to reverse, and she can put her arms stand in front, and is almost unable to put their forehead against the hand of the examiner. Donc, this patient is a very probable patient with INPH. Our results, when the patient that have the ICP monitoring, we have an analyzer that show an amplitude more than 9-10 millimeters of mercury during overnight monitoring. We consider this patient like INPH for the intervention. After the test and after shunting, in our series, we have 90% of patients that have a bladder function and gait amelioration. But in now neuropsychology test, only 60% of amelioration. And after 1 year, some patients have a little more amelioration, but the worst symptom to ameliorate after the shunting is the neuropsychological troubles. For the ICP monitoring complication, permanent none in our department, and transient only for the gait disturbance and cognitive troubles, but this patient have an amelioration, their symptoms some weeks after the monitoring. And after that, we put the shunt. But it's very important that you have no infection, no hematoma, and no leakage CFS after ICP monitoring. It's very invasive, but in our department, we didn't have any complication. Here, I try to see the control we can make to the catheter position, but I don't know if you know the Zigo active. It's for the spinal surgery, but it's the same procedure. And with this kind of machine, we can make a fusion of the image, this image take during surgery, and fusing with the CT scanner made some weeks ago, no problem. And we can see if the catheter is a good position. We use this kind of control for slit ventricle, is more indicate, but we can use for the hydrocephalus too, because many patients without control can have a malposition of this catheter. In conclusion, in our department, we use the ICP monitoring because it has a great reliability to estimate this kind of patient. The most important data analysis is the recording during overnight monitoring. All patients kept under close surveillance during monitoring for 1 day. After that, they can go home. And in our experience, this kind of monitoring has a low risk of complication. Like I said, no infection, no hematoma, no leakage of CSF, only the transient aggravation of the day and the cognitive function, excuse me, that can recover some days after the procedure. Thank you very much.
Okay, Geraldo, thank you very much for taking the time. Excellent presentation.